Pediatric Nursing Certification Review Preparation Course. Chapter 12, Central Nervous System Conditions, by Teresa Miller. Teresa Miller is an Associate Professor of Nursing and the Accelerated BSN Coordinator at St. Xavier University in Chicago, Illinois. Her specialty is pediatric nursing, and she is a published author and has presented nationally and internationally on flipped classroom experiences using simulation and concept maps. She is a board-certified pediatric clinical nurse specialist working with medically fragile, technology-dependent children.
This module will enable the learner to describe alterations in sensory, integrative, and motor functions of the central nervous system, discuss interventions to promote the growth, development, safety, care, and comfort of a child with alterations in any component of the sensory arc, and finally, differentiate among multiple disorders that can cause increased intracranial pressure or loss of consciousness. An overview of neurologic function and several exemplars will also be presented. What are the normal functions of the central nervous system? The central nervous system is a communication system that receives sensory stimuli from external or internal environments. The central nervous system perceives, integrates, interprets, or retains the stimulus in memory. The stimulus commonly results in a motor response. The sensory function of the central nervous system revolves around the 5 senses, including vision, hearing, tactile, taste, and smell. The sensory arc involves reflexes as the message is carried to the brain, interpreted, and acted upon. Reflexes are the infant's early response to stimuli. They are primarily motor reflexes as the infant learns to discriminate stimuli and bring motor responses under conscious control. The older child uses language rather than reflexes to improve and increase perception. A key point to integrate into caring for a child with a central nervous system dysfunction is to use a family-centered and interdisciplinary approach. What can go wrong with the central nervous system and cause dysfunctions? Defects in any phase of the central nervous system can alter sensory, integrative, or motor function. The degree of disability depends on the amount and location of damage. For example, was the motor cortex affected, altering motor function, or was the speech center affected, altering speech? Damaged nerve cells cannot be replaced. Different neural pathways may develop to help compensate for the damaged cells. The later a part of the nervous system develops in embryonic life, the more susceptible it is to injury. Overload or deprivation of stimuli results in altered CNS functioning. Overload. Think of the infant born with heroin or cocaine exposure whose central nervous system is on fire. Conversely, think of the child deprived of physical touch. Flaccid muscles usually indicate a central nervous system disorder. Remember, the central nervous system involves a sensory arc that results in a muscle response. So the infant with hypotonic movements may have an underlying neurological condition. Increased intracranial pressure, ICP, and altered state of consciousness are common symptoms found with central nervous system dysfunction. Let's look more closely at these symptoms. The first prominent clinical manifestation is increased intracranial pressure. Increased ICP may be caused by inflammation, tissue enlargement, or increased fluid accumulation. There may be an increase in the production of cerebral spinal fluid, decreased absorption of excess cerebral spinal fluid, or tissue swelling from trauma, infection, or obstruction. A persistent increase in ICP destroys healthy brain tissue and alters mental function. Your assessment. Assessment of the child before the closure of cranial sutures is discussed with hydrocephalus later in this presentation. Assess the following after the closure of cranial sutures. Observe for signs of nausea and vomiting and headache. Take into consideration the age of your patient. Ask the parents or caregiver for their impressions and history of nausea, vomiting, or headache. Assess and record vital signs. Note any increase in blood pressure, a decreased pulse rate, decreased respiratory rate. Signs can deteriorate to the point of respiratory and cardiac arrest. Use an early warning system tool such as PEWS, the Pediatric Early Warning Scale, to obtain a baseline and status changes. Assess for blurred vision, papilledema, and altered pupil reaction to light. Monitor for personality changes. Observe for and monitor seizures. Assess for an altered level of consciousness with decreased attention or lethargy. Observe for altered or regressed developmental milestones. For example, motor skill alteration, such as clumsiness or loss of balance. Your interventions. Elevate the head of the bed slightly to decrease cerebral edema. Administer an osmotic diuretic, such as mannitol, to decrease cerebral edema. Administer corticosteroids to decrease brain inflammation. Prevent constipation, to prevent complications from bearing down using the Valsalva maneuver. You may need a bowel program for your patient. Consult a dietitian. Limit fluids to decrease blood volume, which will reduce cerebral edema. Maintenance fluids may be kept at 3/4 usual. Include IV and oral maintenance fluid therapy in your I&O. Monitor fluids and electrolytes. Elicit assistance from parents to save diapers or urinal contents for you. Perform hyperventilation with a bag valve mask device, if ordered, to decrease CO2 levels. Monitor the child's level of consciousness. Avoid activities that might increase ICP, including pain, seizures, fever, stress, crying, coughing, straining, and non-therapeutic touch. Include the family and child life therapists or volunteers to provide non-pharmacologic comfort activities. The second prominent sign is altered level of consciousness, LOC. LOC is the earliest indicator signaling an improvement or deterioration in the child's neurological status. The LOC measures the child's response to stimuli. Components of the LOC include alertness and cognitive function. Alertness is the conscious state of the child. Stages of decreasing consciousness include confusion, delirium, obtunded, stupor, and coma. Alteration in level of consciousness may last for hours to days. The second component is the cognitive function. This involves a response to painful stimulation and verbal response to questions or commands. What should be assessed to get the best picture of the child's level of consciousness? Take a detailed health history. Ask the parents or caregivers how their child normally presents and what is different now from yesterday or last week. Parental impressions count. Next, complete a physical assessment that concentrates on the neurological exam, description of behavior, pain assessment, headaches, visual disturbances, vital signs, the pupil size, including the reaction to light, movement, and blinking, motor function response. Is there spontaneous activity? Is there a response to painful stimulus? Are there treasures? Seizure activity. Posturing. Is there any decerebrate or decorticate posturing? Reflexes, including Koenig and Brudzinski, which will be presented later. Look at the skin integrity. Assess for trauma, lacerations, ecchymosis, hematoma, petechiae, bites, or any tick marks. The Glasgow-Coma scale will be presented in the following slide. The Glasgow-Coma scale is used to measure level of consciousness, severity of a brain injury, and the prognosis. The scale may be used with any age group and is modified for infants, children, and nonverbal patients. Scores range from 3, indicating a deep coma state, to 15, fully awake state. The mid-range scores between 3 and 8 may indicate a coma state. Assess 3 areas and note the best response. As with all assessments, begin with observing your patient. What is their best eye movement? No eye movement at all? Do they open their eyes when you enter the room, touch them, speak to them? Second, what is their best verbal movement? Is there no response at all? Do they alert to your voice and turn toward you, speak coherently, or attempt to answer your questions with a communication assistance device? And third, what is their best motor response? Again, is there no motor movement at all? Are they able to follow a command or have an intact reflex response if they are an infant? Diagnostic tests and labs vary by dysfunction. Additional consideration is included with specific conditions. Consents are required for the diagnostic imaging procedures. Educate the parents, caregivers, and patient when appropriate prior to the procedure. Child life therapy may assist with distraction or sedation may be necessary. The lumbar puncture. As the picture depicts, a patient may be in a side-lying or curved sitting position. The lumbar spine is accessed with a catheter. Fluid is retrieved and observed for clarity and color, and glucose level, as glucose is a major component of cerebrospinal fluid. A specimen will be sent for culture and sensitivity, and the pressure in the spinal column can be measured. Medication may also be administered intrathecally during the LP. The MRI. An MRI is used to determine areas with abnormal tissue, tumors, traumatic brain injury, congenital anomalies, multiple sclerosis, infection, stroke, or to define causes for headaches. The CAT scan. A CAT scan is used to detect bone or vascular problems, visualize the brain and spine for congenital or acquired anomalies, tumors, brain bleeds, blood clots, or encephalitis. An EEG, or electroencephalogram, is a non-invasive procedure that records electrical brain activity. It assists in the diagnosis of seizure disorders, head injuries, dizziness, headaches, brain tumors, or sleeping disturbances. An EMG, or electromyogram, records electrical activity of muscles. It helps to diagnose muscle weakness, nerve irritation, or nerve injury. Physical and psychological preparation for the test depends upon the age of the infant or child. Finally, your blood work. A CBC, a complete metabolic panel for lights, specific medication levels, glucose level, or lead level may be ordered. Let's move on to the dysfunctions themselves. What is hydrocephalus and what can cause hydrocephalus? Hydrocephalus is an increase in the amount of cerebrospinal fluid in the ventricles and subarachnoid spaces of the brain. It is caused by obstruction to the flow of cerebrospinal fluid in the ventricular system. This is known as non-communicating hydrocephalus, or by impaired absorption of the cerebrospinal fluid in the arachnoid space. This is better known as communicating hydrocephalus. Another cause of hydrocephalus is Arnold-Chiari malformation. That's Chiari. Arnold-Chiari is the downward displacement of cerebellar components through the foramen magnum into the cervical spinal canal. It is common in hydrocephalus associated with spina bifida. Hydrocephalus may be acquired as a result of intraventricular hemorrhage, IVH, as seen in some premature infants, with an infection such as meningitis, or as the result of head trauma. What do you want to assess? Measure and record the child's head circumference. Note a rapid increase in size. Use a standardized chart such as the CDC or WHO growth charts to record your data. Observe for full, tense, bulging fontanelles, anterior and or posterior. Fontanelles may be open after closure in an infant due to the increased pressure from excess fluid. Check for widening suture lines in infants or bossing in the forehead or frontal area or back of the head. Observe for distended scalp veins. Assess for irritability or lethargy. The older child may have decreased attention span. Note a high-pitched cry. Note sunset sign, This is where the sclera are visible above the iris. Observe the child's inability to support their head when upright. Percuss the skull. Do you note a cracked pot sound? Perform transillumination of the skull. The light will reflect off of the opposite side of the skull. If your child is post-shunt insertion, observe for signs of shunt blockage, as evidenced by signs of an increased intracranial pressure, increased head circumference, and a full fontanelle. Also, observe for signs of infection. What is your nursing care status post-shunt insertion? Include the following. For the first 24 hours, lie the patient flat to prevent headache and loss of fluid from gravity. Do not lay the child on the shunt. Do not compress the shunt without provider order. Support the child's head when the child is upright. Provide proper skin care to the head. Turn that head frequently. If the caudal end of the shunt must be externalized because of infection, keep the bag at ear level to prevent an increase or decrease in intracranial pressure. Report signs of infection or shunt malfunction to the provider immediately. Signs include fever, vomiting, lethargy, pain at the site, headache, bulging fontanelles, widening suture lines, seizures, or a decrease in school function. Provide pain management. Remember, care and comfort can be pharmacological and non-pharmacological. Maintain latex precautions. Some latex products include balloons, catheters, latex gloves, some bandages, some nipples and pacifiers, and some foods. Check labels. NeuroChecks is ordered with an evaluation of cerebral perfusion. Provide family-centered and teach the parents the signs of increased intracranial pressure, infection, and shunt malfunction. Neurological dysfunction related to congenital defects secondary to neural tubes is presented now. Neural tube defects are a group of related CNS birth defects that arise from inappropriate closure of the embryonic neural tube. Each type of neural tube defect varies in the severity of associated clinical symptoms. Neural tube defects are multifactorial in origin, associated with a deficiency in maternal folic acid around the time of conception. This may occur because not enough folic acid is taken by the mother, or the mother does not have an adequate pathway to absorb the folic acid. There are several types of neural tube defects classified according to the portion of the central nervous system involved. The first is anencephaly. This is a condition in which both cerebral hemises are absent. The brainstem and the cerebellum may be present. This condition is incompatible with life. Many infants are born stillborn or die within hours of birth. Organ donation is a consideration among anencephalic infants who are born living. The second, encephalocele, is a condition involving herniation of the brain through a defect in the skull, resulting in a fluid-filled sac, sometimes with brain tissue inside. Meningocele is a condition involving the hernial protrusion of a sac-like cyst containing meninges but not spinal cord. And finally, the myelomeningocele is a condition in which the posterior portion of the vertebral laminae fails to close anywhere along the spinal cord, resulting in a protruding sac. This contains cerebrospinal fluid, meninges, and a portion of the spinal cord. It is the most common type of spina bifida. A myelomeningocele is the failure of the spinal cord to close. This closure usually occurs in 3 to 4 weeks gestation. Multiple handicaps can result because the spinal nerves are in the sac rather than in the spinal cord. The defects can be found early in gestation, and the amniotic fluid will contain high levels of alpha-fetoprotein from the liquid cerebrospinal fluid. Let's look a little more closely at spina bifida, one of those neural tube defects. The assessment for a child with spina bifida includes: check for leakage from the sac. As you can see from the picture, the sac is visible in the lumbar area. In some instances, the sac might not be present, but a dimple and/or tuft of hair may be present. Check for infection around the sac. Assess for signs and symptoms of CNS infection. Assess for motor activity below the sac. Nerve innervation may be impaired below the level of the sac. Measure and record the head circumference to establish baseline data. Remember, hydrocephalus may occur as the result of obstruction from the sac. And assess bowel and bladder functions and patterns. Your preoperative interventions include provide emotional support to the parents. Be aware that surgery usually occurs 24 to 48 hours after birth, so encourage bonding. Prevent trauma by keeping pressure off the sac. Keep the child on one side with the knees flexed or on their abdomen. Institute measures to keep the sac free of infection. Avoid contamination from urine or stool. Prevent the sac from drying. Cover it with saline-soaked sterile dressings. Your postoperative assessment. Note the degree of leg movement in response to discomfort. Note the degree of sensitivity to touch below the level of the lesion. Paralysis is possible. Observe for club foot. Observe for dribbling of urine, distended bladder, or the involuntary release of stool. This may indicate a neurogenic bladder or bowel. Observe for signs of increased intracranial pressure related to the hydrocephalus, possibly related to scarring of the spinal area and reduced absorptive space that occurs following surgery. Measure the head circumference. Note if the child is meeting developmental milestones and consult with a developmental therapist, physical therapist, occupational therapist, and perhaps a speech therapist. Postoperative interventions. Provide family-centered interdisciplinary care as mentioned above. Provide routine postoperative care. Assess for signs of infection. Provide pain management. Provide thorough skin care. If paralysis occurs, consider placing the child on sheepskin. Provide orthopedic appliances if necessary. Prevent constipation. Promote range of motion. Perform clean, intermittent catheterization as ordered. Be aware of an increased incidence of latex allergies in this population. As stated previously, with latex allergy, avoid elastic and rubber pants, nipples, pacifiers, and in older children, condoms. Also, beware of cross-reactivity with kiwi, bananas, and avocados that can result in an allergic reaction. Let's move on to neurologic dysfunction related to interrupted brain activity, seizures. Let's begin by describing seizure activity. A seizure is a sudden, episodic, involuntary alteration in consciousness, motor activity, behavior, sensation, or autonomic function. The following 5 slides provide detailed information on the major classification seizures. Nerve cells become hyperexcitable and surpass the seizure threshold. The neurons overfire without regard to stimuli or need. Seizures are the most common neurological dysfunction in children. What does the nursing assessment involve? Obtain a detailed history. Ask if the child experiences an aura, the preictal phase, a peculiar sensation just before the seizure's onset, such as unusual taste, feeling, odor, or visual sensation. Determine the nature of the seizure, the muscles involved, their position, symmetry or asymmetry of movement, the child's level of consciousness, and respiratory status, and whether the child remains continent or incontinent during the activity. Determine the postictal response, whether the child is oriented to time and place or drowsy and uncoordinated immediately following a seizure. Note any alteration in the EEG. What are your goals of treatment? Well, certainly to control seizure activity and minimize the effects of the seizures. You want to reduce seizure activity, frequency, and severity. Identify the causes when able, and assist the family and child to lead a normal life. Your nursing interventions will include pad the crib or bed for any child with a history of seizures. Stay with the child during a seizure. Do not try to interrupt the seizure. It is best to allow the child to seize without interfering unless the child is in an unsafe place or near potentially harmful objects. If necessary, move the child to a flat surface away from objects and out of danger. Do not restrain the child during a seizure. Maintain a patent airway. Do not place anything in or near the mouth. If the child becomes cyanotic or hypoxic, administer oxygen when the seizure ends and regular respirations resume. If the child becomes cyanotic, again, administer the oxygen when the seizure ends. Place the child on their side to let saliva drain out and allow tongue to fall forward and open airway. Record and document seizure activity. Note the time the seizure starts and ends. Note the movement or nature of the seizure. Was the activity symmetric versus asymmetric? Was there movement versus just a staring activity? Administer medications as ordered, such as phenytoin, Dilantin. The mechanism of action keeps the neuron excitability below the seizure threshold. Side effects include gum hyperplasia, hirsutism, ataxia, gastric distress, nystagmus, anemia, and sedation. Another seizure medication might include phenobarbital, Tegretol, or valproic acid. Diastat, Valium, per rectum may be ordered for treatment during a seizure. Monitor the serum levels of anticonvulsant medications, such as the phenytoin, to ensure therapeutic levels and prevent toxicity. Your child may be placed on a ketogenic diet. The ketogenic diet is a high-fat, low-carbohydrate diet that causes the body to burn fat for energy. Foods include meat, fish, eggs, cheese, and natural fats. Avoid sugary foods, such as grains, fruits, beans, or potatoes. Involve the dietitian in teaching the family. Therapeutic management may include a vagus nerve stimulator, a VNS. Educate the child as appropriate and family regarding this adjunct therapy. A VNS is indicated for children 12 years and older and whom medication has not been effective. Electrodes are tunneled under the skin and stimulate the left vagus nerve, cranial nerve 10. Instruct the patient and parents in all aspects of seizure control measures. Please see the slide on the teaching tips. Please take some time to review the next 5 slides to learn more about the classifications of seizures and how they affect children. Go through the slides at your own pace. You'll see that they include partial seizures, generalized seizures, still more generalized seizures, and miscellaneous seizures. Again, take some time to review the teaching tips found on this slide. These points should be included in your teaching and discharge plan for a child with a seizure disorder. The neurological dysfunction related to infection exemplar is meningitis. What is meningitis? Meningitis is an inflammation of the meninges, and it's caused by viral or bacterial agents and transmitted by the spread of droplets. Organisms enter the blood from the nasopharynx or the middle ear. The condition is common in infants and toddlers. Its incidence is greatly decreased with the administration of Haemophilus influenza type B vaccine. The nursing assessment includes clinical manifestations related to increased intracranial pressure and infection, so note the presence of seizure activity. Observe for signs of increased intracranial pressure, such as vomiting and irritability. Infants and young toddlers may exhibit a high-pitched cry, bulging fontanelle, and poor feeding. Older children and adolescents may exhibit nuchal rigidity and headache. Assess for abnormal postures, such as the hyperextension of the neck and spine, which may be present later in the course of the illness. Look for the reflexes I alluded to earlier in the presentation. Brzezinski's sign. The child will flex their knees and hips in response to passive neck flexion. Look at the Kernick sign. The child will complain of pain when they flex their knee and raise their leg. I kind of think of this as the Kermit the Frog sign. Observe for petechiae, or purpuric rash, which is associated with a particular bacterial infection, meningococcal meningitis. Check ear drainage for cerebrospinal fluid. The presence of cerebrospinal fluid will give positive glucose results. Note that the lumbar puncture will show increased cerebrospinal fluid pressure, a cloudy color, increased white blood cells and protein counts, and a decreased glucose count if the meningitis is caused by bacteria. Your nursing interventions. Maintain a patent airway, breathing, and circulation. Institute seizure precautions. Assess pain and provide pain management, both pharmacological and non-pharmacological. Isolate the child for at least 24 hours after antibiotic therapy begins. Assess the child's neurologic status. Do this frequently to monitor for increased intracranial pressure. Provide a low stimulus environment. Turn off or down the lights. Turn off the TV and radio. Maintain a quiet zone. Avoid perfumes and heavy scents. Keep the child flat in bed. Move the child gently. Administer parenteral antibiotics as ordered. Have suction and resuscitation bag at bedside. Remember to educate the parents regarding meningococcal immunizations for children and adolescents. The next neurologic dysfunction to discuss is related to brain tumors. Brain tumors are the second most prevalent type of cancer in children. It is the most common form of solid tumor in children. The condition is commonly diagnosed when the child is between 5 and 10 years. 1/2 to 2/3 of brain tumors in children are infratentorial, commonly involving the cerebellum or brainstem. Remaining tumors are supratentorial and mainly involve the cerebrum. Gliomas are the most common brain tumors in children. They include medulloblastoma, astrocytoma, ependyoma, and craniopharyngioma. Prognosis varies based on the type and location of the tumor. The exact etiology is unknown. However, it is suspected the radiation exposure and environmental factors are present. What to include in your nursing assessment? Symptoms stem from the tumor's pressure on adjacent neural tissues and or on the flow of cerebrospinal fluid, so assess for acute pain. The young child is typically difficult to diagnose because of the elasticity of the skull and normally poor coordination. You may see an increase in intracranial pressure. Alterations in neurologic function, especially visual acuity and behavior changes, may occur, including a decline in school performance. The child may experience growth failure, precocious or delayed puberty. Headache, commonly an initial sign, usually occurs in the early morning and during sneezing, coughing, and straining. Vomiting unrelated to eating, hypotonia, posturing, seizures, and altered vital signs may occur. Other common signs and symptoms include ataxia, the uncoordinated gait, a cranial nerve palsy, anorexia, head tilt, nystagmus, decreased reflexes, vertigo, and a change in dexterity. Assess for signs and symptoms of craniopharyngioma, pressure on the pituitary resulting in diabetes insipidus, any visual problems, difficulty regulating body temperature, altered growth, and altered cerebrospinal fluid pressures. These are the nursing interventions to provide preoperatively. Prepare the child and family for a CAT scan or MRI. Prepare the child and family for radiotherapy prior to tumor removal in an attempt to shrink the tumor. Advise the child and parents to expect facial edema and hair loss from chemotherapy. Prepare the child and family for surgery and potential complications that may include hydrocephalus, sensory motor deficits, seizures, and endocrine dysfunctions. Correct fluid and electrolyte imbalances. Monitor intake and output and urine-specific gravity. Maintain nutritional support. Discuss surgical preparation and need for shaving of the site. Here are the nursing interventions for the postoperative period. Position the child on the non-operative side to minimize pressure and prevent the brain from shifting into the space vacated by the tumor. Make sure the child lies flat on either side if surgery was infratentorial to maintain a steady ICP. Elevate the head of the bed slightly if surgery was supratentorial to promote venous drainage. Monitor the VP shunt if one was placed. Observe for signs of malfunction, increased ICP, suture line infection, and hemorrhage. Provide care to the incision as ordered by the provider. Monitor the vital signs, check the pupils, and report any inequality or sluggishness. Document assessment and report status changes to the provider immediately. Assess pain with an age-appropriate pain scale. Provide pharmacological and non-pharmacological pain management therapies. Maintain proper body alignment. Log roll if ordered. Assess the child's level of consciousness and ease of arousal. Note any changes indicative of increased intracranial pressure and report immediately. Relieve eye edema with cold compresses and lubricate the eyes to prevent corneal irritation. Prevent increased intracranial pressure by telling the child to avoid straining for stool or coughing forcefully. Monitor intake and output and urine-specific gravity. Initiate seizure precautions. Administer vasopressin, if ordered, to treat diabetes insipidus for craniopharyngioma and replace lost fluid as ordered. Encourage the family and patient to talk openly about the diagnosis, prognosis, and treatment. Refer to psychological services as needed. Finally, let's talk about neurological dysfunction related to head trauma. It is important to know how to care for a child with a neurological dysfunction related to head trauma. What are some facts related to head trauma? Head injuries are a common cause of death in children older than 1 year. Infant head trauma usually results from falls by young children from changing tables, beds, furniture, stairs, walkers, being shaken, or motor vehicle accidents. Older child head trauma usually results from motor vehicle accidents, falls from bikes or skateboards while not wearing a helmet. Adolescent head trauma may result from motor vehicle accidents from not wearing seat belts, from a skiing accident, fall from a bike or skateboard while not wearing a helmet, sports injuries, and alcohol or drug-related accidents. The extent of the brain injury is directly related to the force of penetration or impact. Short-term or long-term disabilities may result from a head trauma. Categories of head injuries include primary. This is seen after the initial trauma. You see an increase in intracranial pressure and possible loss of consciousness and apnea. Secondary brain trauma is one that occurs hours, days, or weeks after the injury. It is the body's response to injury. Signs include hypoxia, hypotension, edema, and hemorrhage. This may result in permanent brain damage if not diagnosed and treated quickly. An epidural intracranial hemorrhage is bleeding into the spaces between the dura and the skull. A subdural hemorrhage is bleeding between the dura mater and the arachnoid layers of the meninges. A concussion is a transient state of neurologic dysfunction caused by a jarring of the brain. It is the most common head injury. It may or may not be accompanied by a loss of consciousness. If not completely healed before resuming activities, another head trauma could result in second impact syndrome, which could lead to sudden death. A skull fracture may be linear, simple, depressed, where a depression of a bone toward the brain, or basilar at the base of the skull. And finally, shaken baby syndrome is now called abusive head trauma and often results in significant tearing of blood vessels with high morbidity and mortality. What should you include in your nursing assessment? For an epidural injury, assess for a recent history of head trauma with or without loss of consciousness. Note increasing headaches, decreasing level of consciousness, contralateral hemiparesis, and bradycardia. For a subdural injury, assess for any type of head trauma, such as from falls, accident, or abuse. For basilar fracture, observe for raccoon eyes and central nervous system rhinorrhea. For a concussion, note the child's level of consciousness and memory of the accident. Assess for headache, dizziness, vision problems, change in emotions or behaviors, sleep disturbances, difficulty remembering, vomiting at the time of the injury and 24 to 48 hours after the injury. Assess for signs and symptoms of increased intracranial pressure. For all, perform frequent neurologic assessments to determine quality of the reflexes, pupillary reflex, and level of consciousness using the Glasgow-Coomer scale previously presented. Assess the vital signs frequently. Prepare for a CAT scan. Check ear or nose drainage for glucose. Remember, cerebrospinal fluid tests positive for glucose. Note behavioral changes, such as aggression, withdrawal, irritability. Watch for alterations in sleep patterns, gait, or school performance. Your nursing interventions to include in your plan of care are: prepare for surgical evaluation of the blood clot and ligation of the bleeding vessel if necessary. Promote bed rest and limit unnecessary body movements. Slightly elevate the head of the bed. Initiate seizure precautions. Provide a quiet environment. Decrease eye strain, including no TV, computer time, reading, or texting, in order to let the brain heal. Awaken the child every 2 hours to assess level of consciousness. Monitor fluid status carefully. Maintain clear liquids until the child has not vomited for at least 6 hours. Restrict fluids as needed to decrease ICP. Prevent injury through family and community teaching programs to stress child safety, including bicycle helmets, car restraining devices, protective skating, and athletic equipment.